partials. A lot of patients have partial dentures, and many of these patients, the partial is holding up their bite. It's creating the bite. So we need the partial. But we also need the partial out for the pin guide. So when a patient has a situation like this, whether they have two partials or one partial, this is going to be a maxillary case. So on the lower, there's no partial. That's okay. Lower crown and bridge impression, upper full anatomy impression with the partial out, and then a study model with the partial in. This helps us set the bite. From that point, we will cross mount so that we can make a pin guide, but the partial will give us this 19-ish, kind of hard to tell, it's denture teeth. But this patient probably is in a good vertical position. And the reason I mention all these Shimbashi measurements is because when you're sitting with the patient, take a ruler, take a perio probe, mark off the CEJ, and kind of just get an idea of where your starting point is. Because then maybe at that point, when you're filling out your RX, you'll tell us, open the bite 4 millimeters, open the bite 5 millimeters, based on Shimbashi. We're going to do some other analysis that's not our stopping point, but you give us a number, you give us a starting point, you give us how much to open, we're further off along. So a little recap on these records. Lower, upper without partial, upper with partial, 2 bite registrations, 1 with the partial out, 1 with the partial in. We will do a cross mount. We will get this case ready and meet you online. Okay. If the partial is wobbly, you can do a hard reline on it. You could use a blue mousse on it. You can establish a nice positively seating partial, or you can send it in and we can make you a JC try-in that'll confirm a nice solid bite. So you always want a prosthetic to have a nice positive seat, not rocking around. All right, another one. This is the anterior part of this denture has, it was surrounding those teeth. Patient lost the teeth. Denture is still holding up the vertical. This situation here, this is probably going to be a dual scan. Not always, but probably going to be a dual scan. And yep, and I put that in the notes here. So this is take the partials out, take an impression, put the partials back in, take a study model of each. We may be able to articulate and move forward. If not, then we will either instruct you to do a dual scan by putting markers on these appliances, which you could do as a first step. That'd be fine too. We'll talk about dual scan in a bit. Or we'd send you some scan appliances in a new vertical. Open the patient up a little bit, do some scans. All right. But upper lower cast, 2 bites, and then study models. And this is just a 15 millimeter vertical. So this patient is going to be open up 2, 3, 4 millimeters, which means that the JC try-ins scan appliances that we send you would be in the new, what we're going to propose as a proper vertical. Mandibular arch. This is similar to before. You can see we have a picture here on the top with no partial, picture in the bottom with partial. And I put this one in here because patients wear their partials down. They lose bone, they wear their teeth down, and this just is not a good record. If it just stands on its own like this, there's a gap in the posterior. So we suggest adding some composite to this partial, doing a hard reline to make it ideal. Now, if you're going to move forward with this, do a blue mousse reline impression. It'll show up in the CT. You can do it if that has metal under it. I think that's just a clasp, and it's a plastic, just a plastic flipper type partial. But you can also just capture a bite showing us the discrepancy in the posterior, use it as a study model, and then send us an impression without the partial in. All right. If you have questions on these at the end, please put them in the chat. Let's talk about them. I think I covered a whole bunch of situations there that'll help a lot. But there's so many different ways that these patients walk in the door. And then with the bites, most of ours are centric occlusion, most bites, but we would love to have centric relation. If you do splint therapy, love it. If you're neuromuscular, love it. We can handle these bites any way you send them in. The JC try-in. So this is what we were alluding to earlier to confirm the bite. And so this patient, came in, centric stops, none in the posterior, patient missing molars, on the upper, missing bicuspids on the lower, right? So difficult to really capture a perfect bite. So we put it on the articulator, we opened the bite a little bit, we made JC try-ins. You can see when you get used to these, there's no markers. This is not a dual scan situation. These appliances go to the mouth. They are adjusted and equilibrated carefully, like a denture. Use paste, adjust until they're seated, no movement, no rocking, very important. Then equilibrate until you have dots everywhere you need on the JCs, right? Because we open the bite, the JCs are open, and they're holding the bite open. Take a physical bite registration and return the JCs and the bite physically. This is not a digital impression modality. We want physical impressions coming back in. And then what we do when we fabricate these, we have articulated cases on the left. That's a digital impression. We have those little struts on there to hold the upper and lower together. And then we open the bite on the articulator and we fill in the gap, the difference, the teeth, the bite, the spaces with the JC try-in. That is what goes chair side to confirm the opening. And here we went from an 11 all the way up to a 17 with a JC try-in Shimbashi measurement. You can just see this is what they look like on the articulator in occlusion, look just like that in the mouth. In this case, you can see, let me go back here a little bit, right here. When a patient only has a few teeth, the JC try-in becomes a scan appliance. All right, so this is equilibrated. You see some dots here. This is equilibrated, and then this will be a dual scan protocol. And I won't go through that process, but dual scan protocol, that's how we register the upper. I think the lower, don't really remember if this one also had markers on the lower. Let me see here. No, there was enough occlusion on the lower. We didn't need to do a dual scan. All right, so there it is closed and the JC holds it open. So the JC is a very, very helpful tool. JC is, the JC try-in is named after our technician who invented it, Mr. Jason Caruth. One of our lead planners, and he invented this because he knew it would help us save time with records. So kind of get the gist of what it is. Okay, so digital impressions, just one quick slide on this. We really accept every digital impression machine scanner on the market. There are some that are certainly better than others for this type of work. Scanning full arch, scanning tissue, scanning the palate, scanning vestibules when they're wet, scanning prosthetics outside the mouth. They're not all the same, but the more you spend, the better scan you get, pretty much. So, choose wisely. We can always have a conversation about which scanner. Happy to give some tips on that. So, why do the records have to be so accurate? Kind of alluded to it much earlier, and that is the first part of a chrome case is the pin guide. The pin guide sits on the teeth, sometimes tissue here, but this pin guide has to seat perfectly in the mouth. If it is held up by models that are distorted, dentition that's changed, over time, on delayed cases, that kind of thing, the pin guide doesn't seat perfectly, can be an issue. There are ways around it, but there can be an issue. So you want the pin guide to just drop in the mouth, confirm with the windows, and off we go because of good records. Not these. We want beautiful master casts. All right, so that was photographs. That was casts and bite registrations. And then we're still on dentate. So let's talk quickly about the CT scan. With our company, we always take a CT scan with the teeth apart for dentate, always. If you're doing JC try-ins on dentate and they have markers with dual scan, little different story, you can do that in occlusion. But as a hard rule, if your dentate means teeth apart, just like this. And then we want a nice big field of view. So the green area is from the lower teeth to up to the sinus, and the low is the upper teeth all the way down to the chin. That's the field of view, the FOV, the field of view. That's what we want to see. Be very careful not to cut off the chin. Often we have cases that come in that the patient was too far forward into the machine and this was cut off. We don't want that. We want to be able to design tooth position, bone reduction, implant placement based on pristine, perfect, yes, perfect CT scans. All right, so that's the field of view. And then when you export your DICOM, and believe it or not, we have about 15 videos on our website for the major popular cone beam systems that show step-by-step how to go through and export your DICOM in single file format. I say multi-file, it's multi-file. So a single set of multi-file DICOMs. Your folder will look like this: 250, 350, sometimes 500 .dcm files. That's what they look like. And then the process is you export them to a folder. Let's just say it's on your desktop for access. And then you just simply right click on the folder, go down to send to, compress zip folder, and a folder right next to it will show up with a zipper on it. And that is what you send us, the zipped folder of DICOM. All right, so with the DICOM, the photos, and the STL files, which kind of didn't mention the two ways of getting us the STL files: ship them in the mail with your bites, old school, perfectly good, love it. If you have digital impressions, you can go through your portal, happens every day, it's just fine, or you can export your STL files with your bite. So there'll be usually an upper, lower bite, maybe some other scans or pictures come along with it. Put that into a folder with your DICOM, with your photos, and upload them all at the same time. That makes the case more expeditious because we're looking for files all in the same place, as opposed to emailing the photos here, uploading the DICOM on our website, sending your STL files through a portal where we have to go gather it all. It's perfectly fine, but makes it more efficient if we have it all in one package, especially if you're working with multiple offices where some records come from one office and some from another. So that was dentate. Let's just quickly go through edentulous. Edentulous is, as far as records go, fairly simple. There are some things to watch out for, but fairly simple and straightforward. And it's always general dentistry with edentulous, right? You want a denture or a scan appliance, but generally a denture. Fitting well, seating well, intimate, no rock, no soft reline. If it doesn't fit, do a hard reline or load it with blue or green mousse on the day the scan is going to happen. And you can do your dual scan with green or blue mousse. Works really well. I got a slide on that. But one of the most important things is print off the checklist. Check it off. It has all the explanations of the photographs, the dual scan, the opposing dentate if it's a single against the dentate, the CT dual scan, the bite registration, all the details are there. Read them every time until you are indoctrinated, know how to take the records. So this is, you can see here we have two separate checklists. One is opposing dentate and one is opposing edentulous, right? They're both common and these are both single arch surgeries. So we also have checklists with edentulous against edentulous and then a couple of other ones like against a hybrid, that kind of thing. So there's all kinds of variations that show up.